fuse with lysosomes, and the lysosomes are contain the hydrolytic enzymes that are necessary to break down and destroy products into their simple building blocks. And so basically what will happen is that a autophagic vacuole will be formed, and the cellular components will be consumed and then destroyed by the lysosomes. So two mechanisms by which the cell size decreases. Number one, ubiquitin proteasome degradation pathway, and number two, autophagy of cellular components. The third growth adaptation, which is also relatively high yield, is metaplasia. Now, the idea here is that if the stress on an organ changes, then the organ will respond by changing its cell type. And that change in cell type is called metaplasia. Metaplasia most commonly involves surface epithelium. So let me step back and explain that for a minute. Epi means on top, and thelium means layer. And so epithelium is the cells that line body surfaces. So the entire skin is lined by epithelium, the gut is lined by epithelium, the urogenital tract is lined by epithelium. For the most part in the human body, generally speaking, keeping things very simple, there's three types of epithelium. Recall that there's squamous epithelium, which can be keratinizing or non-keratinizing, but generally speaking, there's squamous epithelium. That's the first type of epithelium. The second type of epithelium is columnar epithelium. A lot of the gut, for example, is lined by columnar epithelium. And the third type of epithelium is called transitional epithelium or urothelium. And that's the epithelium that predominantly lines the urinary tract. Metaplasia, generally speaking, involves surface epithelium. And the idea behind metaplasia is that the metaplastic cells are better able to handle the new stress, so that when there's a change in stress, the metaplasia occurs because the new cells that are going to be present are better able to handle that stress. And let's maybe highlight some of this with a simple example, which is Barrett's esophagus. Now, what is Barrett's esophagus? So let's go back and remind ourselves. Now, the esophagus is lined by squamous epithelium, and recall that there is a very sharp demarcation between the esophagus and the underlying stomach. And the stomach, instead of being lined by squamous epithelium, is lined by columnar epithelium. So again, esophagus is lined by squamous epithelium, and the stomach is lined by columnar epithelium. If acid refluxes from the stomach up into the lower esophagus, then the reflux of acid into the lower esophagus results in a change in stress in that lower portion of the esophagus. And that change in stress, i.e. the presence of acid within the lower portion of the esophagus, will result in the lower portion of the esophagus going from squamous epithelium to a columnar, non-ciliated, mucinous type of epithelium. Again, it's important to know these details. Columnar, non-ciliated, mucinous type of epithelium. And the idea here is that columnar epithelium is much better suited to handle acid, and so when acid shoots up from the stomach into the lower esophagus, the cells in the lower esophagus basically change from squamous to columnar in order to better deal with the stress of acid. And this change to columnar epithelium, this metaplasia, this is called Barrett's esophagus, and it's a classic example of metaplasia. Here's a histologic image that can classically show up on exams, and so I put this here as figure 1.2 in your text. This is squamous epithelium here. This is the normal squamous epithelium of the esophagus. And this squamous epithelium should actually come all the way across the esophagus. However, in this portion of the esophagus, we can see that the squamous epithelium has converted to columnar epithelium, and focally that columnar epithelium exhibits goblet cells, or mucin, or droplets of mucus within the cytoplasm of the cell. Now, the next point about concerning metaplasia is how metaplasia occurs. Remember that I told you it's not sufficient to simply know the definition of metaplasia, but you also need to know the mechanism by which it occurs. And the mechanism by which metaplasia occurs is via reprogramming of stem cells. So there are stem cells present, for example, in the lower, in the esophagus, in this case the lower 1/3 of the esophagus, and those stem cells have the ability to produce new squamous cells. If they see acid, they begin to say, well, squamous cells aren't good at dealing with acid, and instead they convert themselves to columnar cells. And when they convert themselves to columnar cells, that results in the metaplasia that we've been discussing. Now, very important to know, metaplasia is reversible. That's a high yield principle. If you remove the driving stress, let's say you remove the key stress that was causing or that led to the metaplasia, that will then result in reversal of the metaplasia. Let's just take a very simple example. If we've got gastroesophageal reflux disease and we've got acid shooting up into the lower 1/3 of the esophagus, that's going to result in a columnar, non-ciliated, mucinous metaplasia. If the acid reflux is ceased, for example, via some sort of therapeutics, then decrease in acid will result in reprogramming of the stem cells back to their original squamous type, and the metaplasia will then reverse. So it's very important. I think the key take-home point from this slide is that metaplasia is reversible. Now, another important high-yield point is that metaplasia can progress to cancer. This is a very important point. And I think we all would appreciate the fact that Barrett's esophagus is a risk factor for the development of adenocarcinoma of the esophagus. And we'll talk about adenocarcinoma of the esophagus in much more detail when we cover the GI lecture. Now, one very important exception, which becomes commonly tested, is that apocrine metaplasia does not increase the risk for cancer. Okay, what's apocrine metaplasia? Apocrine metaplasia is one of the changes that's seen in association with fibrocystic change of the breast. The fibrocystic changes can be associated with an increased risk for the future development of breast cancer. However, apocrine metaplasia does not increase the risk for future breast cancer. And that's important because although it's a metaplasia, it does not increase the risk for cancer. So please keep that in the back of your mind. Another important principle concerning metaplasia is that vitamin A deficiency can result in metaplasia. Before you can understand this, we need to go take a step back and maybe stick a couple other high-yield points in here. Let's start with vitamin A deficiency. So when you think about vitamin A deficiency, the very first sort of thing that comes to mind is night blindness. And I think that we're all familiar with the fact that if someone is vitamin A deficient, there's an increased risk for night blindness. Another important feature of vitamin A deficiency to bear in mind is that patients who are vitamin A deficient, they can become deficient in their immune system as well. And vitamin A is necessary for proper maturation of the cells of the immune system. A classic example, maybe you recall this, when patients get a 15-17 translocation, they develop a disease that's very high yield, which is called acute promyelocytic leukemia. Now let's go back and remind ourselves, the 15-17 translocation involves the vitamin A receptor, retinoic acid receptor, in fact. And so when that 15-17 translocation occurs, it disrupts the vitamin A receptor, and that disruption of vitamin A receptor causes the cells to remain trapped in the blast state, and therefore they accumulate, resulting in a promyelocytic leukemia. And if you want to dig a little deeper, you can remind yourselves that from pharmacology, one of the treatments for PML, or promyelocytic leukemia, is ATRA. ATRA is also known as all-trans-retinoic acid, and it's a derivative of vitamin A. So this derivative of vitamin A has the ability to bind the mutated receptor, which then allows the cells to actually mature and become neutrophils. I just go off on that tangent because it allows me to remember that vitamin A is necessary for maturation of the immune system. That's the second principle. And by the way, we'll talk about promyelocytic leukemia in much more detail when we do the leukemia lectures. The third consequence of vitamin A deficiency is that it can result in metaplasia, and that's what we want to talk about here. Now, let me just take you back a step and remind you that vitamin A is necessary for maintenance of specialized epithelia in the body. For example, the conjunctiva of the eye. The conjunctiva of the eye refers to a very, very thin, delicate membrane that covers the surface of the eye, and for the most part, we don't even appreciate that membrane. The time that you recognize that that membrane is there is when it becomes inflamed, and so, for example, when a patient gets a cold and they come in with pinkness or redness to the eye, that is an example of the conjunctiva becoming inflamed and hence becoming red. But for the most part, the conjunctiva is not visible. It's a very thin, delicate membrane that overlies the surface of the eye. The conjunctiva is actually a very highly specialized squamous epithelium. And that highly specialized squamous epithelium requires vitamin A in order for it to remain in that state. If there's a vitamin A deficiency, that can then result in metaplasia of those cells, and metaplasia of those cells that line the surface of the eye can then result in a thickening of that surface, which is called keratomalacia. I'll show you a classic picture. This is a picture of the conjunctiva of the eye. Now, normally the conjunctiva of the eye should be absolutely transparent. However, we can see here that it's become thicker. And it's become thicker because there's a vitamin A deficiency, and the vitamin A deficiency results in an inability to maintain that highly specialized surface that covers the eye. Again, this is relatively high yield. In addition, the next principle concerning metaplasia is that mesenchymal tissues can also undergo metaplasia. All right, take a step back. So what are mesenchymal tissues? Well, the mesenchymal tissues include things like bone, blood vessel, fat, cartilage. These are all mesenchymal, also known as connective tissues. Now, the mesenchymal tissue can also undergo metaplasia, and the classic example is myositis ossificans. So what happens in myositis ossificans? Well, in myositis ossificans, inflammation of the skeletal muscle results in a metaplastic production of bone within the skeletal muscle. Now, why would the skeletal muscle be inflamed? It's usually due to trauma. So a patient undergoes trauma of the skeletal muscle, and when the skeletal muscle is healing, there's a certain degree of inflammation, and as part of that healing, the skeletal muscle actually converts into bone, and some bone is produced within the skeletal muscle. That's called myositis ossificans, and that is relatively high yield as well. This is a classic picture. It's figure 1.4 in your text, and this circular area here that looks ossified within the muscle, this is the myositis ossificans, or the presence of bone within skeletal muscle. Now, be careful, because examiners like to tell you or make you think that, or confuse you perhaps, that this is actually an osteosarcoma. However, notice that this, number one, this bone is normal. The bone adjacent to it is normal. And number two, if you look very carefully, you can see that there is a distinct separation of this bony metaplasia with the actual bone next to it, highlighting that this is actually occurring within the muscle and is not growing off the bone. And osteosarcoma, which is a malignant bone tumor, would actually grow off the bone. So that's an important image to be familiar with. The next principle in growth adaptations is dysplasia. And dys means bad and plasia means growth. And the idea with dysplasia is that there is disordered cellular growth. For the most part, the term dysplasia is used to refer to a proliferation of precancerous cells. The classic example of dysplasia is CIN. We're all familiar with this in the cervix, cervical intraepithelial neoplasia. Recall that CIN can be subdivided into three types: CIN1, CIN2, and CIN3. And it's important to remember that CIN is actually dysplasia. Dysplasia usually arises from long-standing pathologic hyperplasia. What would be an example of long-standing pathologic hyperplasia? Endometrial hyperplasia, which can eventually undergo dysplasia and then become endometrial carcinoma. Dysplasia can also arise from metaplasia. What would be an example of metaplasia? Barrett's esophagus. Barrett's esophagus can become dysplastic, and the dysplasia can eventually become adenocarcinoma of the esophagus. Now, important to remember that dysplasia is reversible. I can't stress this enough. Dysplasia is reversible. If you remove the inciting stress, the dysplasia can potentially reverse. For example, if a patient has gastroesophageal reflux disease and the GERD is treated, then the dysplasia can actually reverse. If the stress persists, the dysplasia can progress to carcinoma, and carcinoma is irreversible. This is the key distinction between dysplasia and cancer. That is, dysplasia is reversible and cancer is not reversible. A couple more quote-unquote plasias that we should discuss. They're not really growth adaptations, but I threw them in here because they fit well with the discussions that we've been having. The first is aplasia. A means without, and plasia means growth. And this is a failure of growth of cell production or organ growth during embryogenesis. And the classic example is unilateral renal agenesis, where a patient fails to develop one kidney during embryogenesis. Another important entity to be familiar with is hypoplasia, or another important term, I should say, to be familiar with is hypoplasia. Hypo means low, and plasia means growth. And so in hypoplasia, there is a decrease in cell production during embryogenesis. This results in a relatively small organ. The classic example would be a streak ovary in Turner syndrome, and that's also that's an example of hypoplasia. All right, so that concludes this section. A lot of high yield, a lot of important things to be familiar with. Again, important to know terms, important to know mechanisms behind those terms, and important to know examples. Luckily, we're going to have many opportunities to review some of these principles as we go through the remainder of the text. So why don't you take some time to review what we've covered, and I'll see you when we get back to the next section.